Hi, my name is Cameron Howe, and I'm with the University of Maryland School of Pharmacy Masters of Science in Medical Cannabis Science and Therapeutics program. Today, we're going to discuss cannabis and autism treatment through the lens of a case study. Hopefully by now, you've all gotten a chance to read the clinical scenario regarding our patient, Ben. If you haven't, no worries. We are going to dive into all these details as we discuss this case and evaluate whether cannabinoid therapy could be a beneficial option for Ben. Here are some case highlights before we get started. Ben is a 10-year-old male with severe autism. He was diagnosed at 15 months old with a level 3 severity, meaning he needs significant assistance for daily living activities. Ben exhibits nonverbal communication, inability to make eye contact or respond to verbal cues, severe aggression with digging of his nails and screaming. He has meltdowns that require parental restraints for safety up to twice weekly. At 2, he was diagnosed with obsessive compulsive disorder with repeated self-harming behaviors such as pinching, biting his hand, and walking only on his toes in an attempt to self-soothe. His parents are very involved and are proactive in getting Ben the services he needs. His parents have utilized a lot of resources to help keep Ben safe in the home. Ben also attends a private school that specializes in autism where he gets one-on-one teaching and an aide. But that's not enough. He's still struggling. And so Ben's parents are hopeful that medical cannabis could help Ben manage his psychiatric and behavioral manifestations of autism. In order to give this patient the best care possible, we need to be thorough in Ben's treatment. We are going to use Scholar Mac to assess the patient. Then we are going to formulate a question that will help guide us in the direction to acquire the best evidence available. We will then take that evidence and appraise it to see if we can apply it to our patient. And finally, we are going to combine our clinical judgment, appraisal of evidence, plus what Ben and his parents want to create a personalized goal and an individualized treatment plan for Ben. The first thing we need to do is assess. We are going to assess this case. Ben is a 10-year-old male. Ben's parents report that they're willing to pay whatever it costs to get him adequate treatment. He also attends a private school for autism, has a strict diet, and regulated social interactions. Ben has severe autism spectrum disorder with a level 3 diagnosis with his main symptoms of nonverbal communication and aggression that are negatively impacting his life. Ben also has concurrent obsessive compulsive disorder that involves repetitive self-harming behaviors. It's important to remember that just because somebody is nonverbal does not mean that they do not communicate. In fact, Ben communicates he has anxiety by his self-soothing behaviors like pinching, biting his hand, and walking only on his toes. Those self-harming behaviors pose a safety risk for Ben and possibly those around him. His parents report that they must restrain Ben twice weekly due to his escalating meltdowns. Ben exhibits an inability to make eye contact or respond to verbal cues. He shows severe aggression when digging his nails, screaming, and having meltdowns to the point that intervention is required to keep Ben safe. We don't know if his symptoms stay the same throughout the day or if they vary in the terms of severity, but that information would be helpful to know. There have been multiple pharmacologic modalities that have been tried to manage Ben's psychiatric and behavioral manifestations of autism. Most were poorly tolerated, or he even had a paradoxical worsening of symptoms that caused him to have to be weaned off that medication. He has tried clonazepam and gabapentin. Both were discontinued due to a lack of efficacy and sedation. His Zoloft was discontinued because it made him more hyperactive. Ben also receives no effects from trying melatonin. Ben has tried inpatient and intensive outpatient programs. He has never tried medical cannabis before. Ben was diagnosed with severe autism spectrum disorder at 15 months old when he did not meet several developmental milestones. He was diagnosed with obsessive compulsive disorder at 2 years old. And while we do not know what makes his symptoms worse, we do know that repetitive self-harming behaviors are his attempts to self-soothe when he's experienced an increase in anxiety. It would be helpful to know what situations or triggers as for his anxiety or causes symptoms to worse. But unfortunately, we don't have that information at this time. And we don't know what makes his symptoms better. Ben is currently taking Risperdal to address his irritability and aggression. He takes Prozac for his obsessive-compulsive behaviors and anxiety. He is on valproic acid for aggressive behaviors, and he also maintains a strict diet to help reduce problematic symptoms. He sees a pediatric and a neurology specialist. He takes probiotics to help with constipation and gut function. He attends a school that specializes in autism where he gets one-on-one teaching and an aide. And his only known allergy is to an antibiotic. Based on the assessment of Ben, there are several questions we need to ask ourselves. The first is, what is the patient or problem we're trying to address? In this case, our patient is a child with autism. Next, we need to know what intervention or exposure that we need to explore. For Ben, the parents want to know if medical cannabis can help him and his behaviors. So medical cannabis is the intervention. The third question is that we need to ask is, what is the desired outcome? The outcome we want to achieve is a decrease in Ben's problematic behaviors, and we want to know if this outcome would be better or worse or the same as standard therapy or a placebo. So the question we need to answer is, in children with autism, can medical cannabis decrease problematic behaviors when compared to a placebo or standard therapy? The PICO question is a therapy question because we want to know if cannabis is an effective treatment for patients with autism. The best type of study design to answer this PICO question would either be a systematic review or meta-analysis, both need to be well done, and that's our secondary source, or a randomized controlled trial for our primary source. Now it is time to acquire research on whether cannabis could help our patient. For this research, I used PubMed with search terms of autism and cannabis or marijuana or cannabinoids with filters of clinical trial, meta-analysis, randomized controlled trial, and systematic review. There are not a lot of high-quality studies available for cannabis and autism, but I was able to find one systematic review that looked at cannabinoids for people with autism spectrum disorder. Systematic reviews are always an appropriate answer to a therapy PICO question, assuming they're well-designed and include high-quality studies. Systematic reviews are great sources because they offer extensive review of current literature and other sources. However, a systematic review is only as strong as the studies included in that review. So, if a systematic review was analyzing studies that were poorly designed or filled with bias, then that systematic review would not be beneficial as evidence for our patient. One pitfall to be careful about when considering a systematic review is the outcomes that the studies include. For instance, they might all be different in type. They could be randomized controlled, open label, crossover study, etc. But they must be all studying the same outcome for the studies to truly be collectively compared to one another. This systematic review did some studies that were looking at the problematic behaviors, caregiver global impression, behavior and communication, but others compared self-injury, hyperactivity, motor deficits, mood, quality of life, etc. Not every study had the same outcomes or measurement tools to determine the results. Some types of bias that are commonly found in this type of study are study selection, as just mentioned, or exclusion bias. For instance, a study might exclude relevant studies and include inadequate studies. Other types of bias could be publication bias, small study bias, citation bias, among others. One type of bias that immediately stood out in the study was a small study bias. Small study bias is concerning because smaller studies sometimes show different, often larger treatment effects than large studies show. This systematic review looked at 10 studies that overall had low participation numbers. For example, the study with the most participants had 188, with the next highest having 60. And then 7 out of 10 of the studies had 20 or fewer participants. Judging a systematic review's validity is reflected by the quality of the individual studies, the criteria in which the systematic methods are applied, and the extent of variabilities among the studies. For this systematic review, several studies had participants drop out in the range of 1.6 to 16.7%. And many of the studies had participants on multiple medications at the same time, with some of the studies not providing specific medications or the percentage of participants on the same medication. These factors hinder the internal validity of this systematic review. For this systematic review, there was an absence of statistical analysis results. The authors report that this was hampered by the heterogeneity of the study design, populations, type of cannabinoids, and particularly outcomes and measures, end quote. Ultimately, this systematic review was unable to determine if cannabinoids had a high efficacy on the core autism spectrum disorder associated problems. And as such, we are unable to use this systematic review as a determining factor for treatment for our patient, Ben. We want to find the best therapeutic objectives. He would likely benefit from trying outpatient services again, since it's been 8 years since he last had intensive outpatient services. Ben's aggression and anxiety are key areas that have a domino effect for his current self-harming behaviors, like self-soothing and his limited verbal skills. Medical cannabis specifically, the cannabinoid, cannabidiol, or CBD, is a non-intoxicating and has been shown to help reduce anxiety and aggression. Delta-9 tetrahydrocannabinol, or THC, has a psychoactive cannabinoid that has intoxicating effects, which could also make his anxiety worse. Based on my clinical education, I believe the addition of a CBD dominant product to his current medicine regimen, coupled with some new techniques, are likely to result in these therapeutic objectives being achieved by this patient. Ben has ASD and OCD with repetitive self-harming behaviors that are increased when he has anxiety. A CBD dominant medical cannabis product could help reduce his anxiety and increase his frustration threshold. Ben's GI issues could also see some relief with medical cannabis. He has never used a cannabis product before, so he should be closely monitored and start with a start low, go slow, and stay low approach for dosing. Ben's parents support him both financially and emotionally. They will be the ones to administer his medications and ultimately make the decision to try cannabis or not. He goes to school which specializes in autism, but he may qualify for additional resources as well. If his parents have not already gotten him on a disability waiver to receive insurance and funding for additional services, that would be an important next step for the family. There are not enough longitude studies to determine any long-term effects cannabis could have on young patients, so Ben's parents would need to weigh the risks and benefits of trying medical cannabis. However, it is important to note that there are multiple synthetic cannabis-related products and one cannabis-derived product that have been FDA approved. None of the patient-related variables would exclude Ben from being able to try medical cannabis with supervision and close monitoring. When starting a cannabinoid therapy, it's important to look at the medication-related variables. For instance, THC causes sedation, so using a cannabis product that contains high levels of THC could result in significant interactions with other drugs that cause sedation, like risperidone and melatonin. These drugs together should be used with caution and closely monitored. CBD and fluoxetine increase each other's levels or effects in the body throughout different methods. But the important thing to take away from this is that Ben should have a modified therapy plan that either finds a new product that is not fluoxetine, or if he stays on CBD, it should be reduced and he should be closely monitored for any negative side effects. Also, there are minor drug interactions with THC in both risperidone and fluoxetine. While the significance is unknown, Ben should be closely monitored, and dosing adjustments of both medications might need to be made to achieve optimal therapeutic benefit. Due to Ben's GI issues, he should avoid oral cannabis because he could have issues absorbing the medication. A more appropriate administration method could be a nebulizer or an inhaler, as he would absorb the medicine through his lungs. Due to Ben's age and to prevent unnecessary damage on his lungs, he should avoid smoking flower or using a vaporizer. Another option is a liquid product that would go under his tongue, or a nasal spray that would be administered up his nose. Any of these options would give Ben therapeutic benefits with good bioavailability. Ben's family needs to consider the cost of the medicine. Insurance often does not cover cannabis, so it could be an out-of-pocket expense for the family. He could choose an FDA cannabis product, but that often comes with a large price tag. Or he could try medical or recreational cannabis products, which will likely be significantly cheaper than the alternative, but there's a greater risk of inconsistency among the products and less government oversight in terms of safety of the product. Based on the evidence I've reviewed and the different related variables identified, there is no absolute reason why Ben could not try cannabinoid therapy in his treatment. CBD has a strong safety profile and does not cause intoxicating effects. Therefore, a CBD-dominant product could be a great addition to achieving therapeutic objectives as previously outlined. I would like to take a moment to discuss a 2018 retrospective study that looked at 60 children with autism with disruptive behavior disorder that was prescribed a CBD-dominant cannabis extract between April 2016 and January 2017 in Israel. They were followed up 7 to 13 months after treatment in August 2017 and found that 73% of children were still on a cannabis treatment. And that following the cannabis treatment, caregivers reported behavioral outbreaks were much improved or very much improved in 61% of patients. Ben would be a great candidate for cannabinoid therapy, as evident by his current aggression, anxiety, and limited communication skills that are hindering his daily functioning and posing a safety risk to himself and others. CBD can decrease his anxiety and aggression, which can provide him with the opportunity to learn coping skills and communication skills. Plus, medical cannabis has been tied to improving gut function and increasing the time spent in restorative sleep, which could improve Ben's quality of life. There are risks associated with cannabinoid therapy, such as high amounts of THC could increase Ben's risk of developing a mood disorder, psychosis, substance abuse disorder, or his ability to function due to THC's intoxicating effects. There are also drug-to-drug interactions that we have previously discussed that are potentially problematic. As such, a collaborative approach in the form of a team treatment meeting with his doctor, specialist, and support system is advised. On a separate note, the high cost of FDA-approved cannabis products versus the cheaper but highly variable dispensary products is something that must be discussed. While Ben's parents report that they will pay whatever it costs to get Ben the treatment he needs, financial hardships could arise in the future, and the longevity of Ben's treatment could be hindered by making costly choices now. All these concerns need to be considered before starting Ben on a cannabis medication. And finally, there are other traditional treatment options that should be considered, like outpatient services, residential treatment facilities, or swapping out his current medication. These traditional approaches could benefit Ben, and they might want to be explored before an alternative treatment like medical cannabis. Ben has autism spectrum disorder, level 3 severity. He has obsessive compulsive disorder with repetitive self-harming behaviors. Based on the research and Ben's parents' desire to give Ben the best possible treatment while maintaining his placement in their home, medical cannabis could be a great addition to his treatment plan. The optimal therapeutic benefits of medical cannabis that could result in a decrease of Ben's problematic behaviors and an increase in his quality of life. By utilizing a CBD-dominant product, the chances of negative side effects are decreased, and therapy goals may be achievable by using this treatment plan. After a collaborative approach with his other providers, I would start Ben on a low-dose CBD-dominant non-THC extract that would require his parents to place drops of the medication under his tongue. I would give them a dropper with measurements so they would know exactly how much they gave him, and I would instruct them of how to keep detailed records of the medication and any side effects. I would start by having them place 1 drop under his tongue once a day in the morning for 3 days, and then 3 drops under his tongue once a day for 5 days. If that is well tolerated, he would then have 3 drops under his tongue twice daily before a meal. Then I would readjust the dose as needed after 30 days from starting the extract. At his 30-day follow-up, I would introduce cannabis nasal spray that is a CBD-dominant non-THC. Again, it would start low and go slow approach, and the spray would be needed for anxiety, for a maximum of 2 sprays per dose, with a maximum of 2 doses per day, with a minimum of 6 hours between administration periods. I would also refer him to a case manager and a counselor for outpatient services. While the evidence for cannabinoid therapy and autism spectrum disorder is significantly limited, There has been evidence that cannabis can help treat anxiety, GI issues, sleep disturbances, and help Ben decrease his problematic behaviors, specifically his aggression. With CBD's strong safety profile, it is an alternative treatment that is worth taking if his family wishes to pursue the potential therapeutic benefits of medical cannabis for their son, Ben. Thank you for your attendance on this cannabis and autism case study. Have a great day.